Hola, doctora. Ya estoy aquí con Lía.
Hi, good morning.
So, well, we thought our meeting in Brazil was at noon, and it was at 6:15 a.m. So we just finished.
Oh my goodness.
Oh my God.
Yes,
Well,
so
we
it was a
thought
tough
our,
morning, but
Brazil was
okay.
at noon and it was at 6. You're very dark.
Can I use my glasses?
Sure.
Okay.
Todavía no desayunamos, pero ahí vamos. Okay, Ray, can you hear me?
Yes, I can. Can you hear me?
Yes, so the first case is gonna be, what's the name? The person,
Ramona Alagali.
is she there?
No, she's having trouble logging in, so I'm working with her on that one.
Okay, if not, then we move to
Carla.
Carla. Is she there yet? No.
She not yet. She's going to
Okay.
log in now.
Okay. And Dr. Mona is, do you remember where is she from?
She's from Libya.
Libya. Mona Alagali. From Libya. Then the second case, I'll check with Carla if she's presenting or if Carolina is presenting. And we are not in the main room yet, right?
Not yet.
Okay. Okay, if you want to put us in the main room so we can see who is joining from which country.
Okay, I'll do that right now.
Buenos días, Carla y Carolina. ¿Quién va a presentar el caso 2 y el caso 3? No las escucho.
Hola Andrea, buenos días. Va a presentar el caso 2. ¿Sí nos escuchas?
Sí, ahora sí.
No. Va a presentar el caso 2 Carolina.
Ok.
Y el caso 3 Chanel. Va a ser la nueva colorectal el siguiente año.
¿Cuál es su
de
nombre?
Chanel Ugarte.
Ugarte. Perfecto.
Estamos en una congreso de la Sociedad de Cirugía, de Pediatría. Entonces yo voy a salir corriendo allá y ellas van a estar aquí. Cualquier cosa después de las presentaciones. Gracias, Andrea. Buen día.
Gracias, buen día.
Hello, Dr. Alagali. Can we test your webcam and your microphone real quick? We see you. We cannot hear you. Can you say something, please?
Do you hear me now? Hear me? How are you? Hi. Hi to everyone.
I think we can hear you.
Yes, yeah.
Okay,
Good
good.
afternoon.
Yeah,
Hi.
everything's
Hear me?
everything's good.
Yeah.
Thank you.
Can we start or still?
Not yet, no.
Yeah. Thank you.
The Dr. Bischoff will announce when we start. It'll be in about 2 minutes.
Yeah. Thank you.
And then your slides will come up and I will move your slides forward for you.
There is a problem in my lab. You can put your slide.
We'll be able to do the slides for you.
Yeah. Thank you.
Okay, we'll start. So I will ask Dr. Mona to come back. Welcome everyone to our monthly International Colorectal Web Meeting. So far, we have pediatric surgeons joining us from Libya, Pakistan, Mexico, United States, Bolivia, Dominican Republic, Yemen, Ukraine, and Uganda. If I miss your country, please type in the chat and we will acknowledge at the end of the presentation. So as the first presenter, we would like to welcome Dr. Mona from Alogali from Libya. So while you're not presenting, remember to mute your microphone. So I'm gonna mute my microphone and welcome Dr. Alogali.
Okay. Start. Hi to everyone. Hi to everyone, and thank you for accepting my case. Start. Okay. I would like to present my case into susception with pathological causes. My case, 7-year-old female patient. This case, first slide, please. First slide. First slide. Last one, this one, not first.
Ray, are you the one sharing the slides?
Yes, I think we had a little conflict there, though. Hold on.
Okay. Nice, nice. You can start?
Yes.
Yes. Okay. I would like to present my case into susception with pathological cause. My case, 7-year-old female patients. This case present to our emergency department due to intermittent abdominal pain with 10 days in duration and has history of non-vomiting, non-bilious vomiting. On general examination, was unremarkable, but per abdomen examination, feeling tenderness mainly in the left upper quadrant without any palpable mass or bare rectal bleeding. Next. Next, please. All biochemical and hematological investigation were unremarkable, but ultrasound finding there is evidence of bowel inside bowel suggests intussusception at the left hypochondrial with suction movement. But the CT scan of the abdomen and the pelvis with IV contrast reveals stomach distended with air fluid level and evidence of dilated small bowel loop, proximal part of the jejunum, and evidence of the bowel mass formed by lumen inside lumen. Mass measuring about 5 and 4 cm at the left hypochondrial region. Next one. Abdominal radiographs show dilated small bowel loops, mainly in the left side, with no air in the distal part. Next. After result of the CT, the patient was taken to the operative room for laparotomy. An inspection, the bowel showed a single intussusception at the 20 cm from the DG junction, with leading point pedunculated polyp 2.9 and 1.6. Intussusception was reduced manually. Part of jejunum with polyp was resected and end-to-end anastomosis was done in 2 layers. And the histopathology report of resected polyp showed juvenile polyp. Next one. This is the intraoperative lesion finding. The patient started orally 4 days post-operative and discharged with an eventual recovery without any complication and follow-up up to date. Conclusion of my case. Intussusception typically presented between the 6 and 36 months of the age. CT scan and ultrasonography are the best investigation tools for early preoperative diagnosis of intussusception. Usually, small bowel intussusception occurs in the terminal ileum due to the Michel's diverticulum or lymphoma. But in this presented case, it was in the jejunal due to the juvenile polyp, which is extremely rare in children. Thank you for all.
Thank you very much.
An intraoperative. This is my colleague and intraoperative, Dr. Abir.
Perfect. Thank you so much for this interesting presentation. I personally have never seen a case like that, so I'm gonna ask the audience if anybody has experience with a juvenile polyp in the jejunum, and please type in the chat. But congratulations on the management, and we're happy that the patient is doing well.
Thank you. Thank you. Thank you very much.
Congratulations for your case.
Thank you.
I have never seen a juvenile polyp in small bowel, but in medicine there are no nevers and there are no always. Everything is possible. But the one message that I learned through my life in dealing with intussusception in older children, you know, the typical intussusception in an infant, you usually reduce that radiologically, and then the patient goes home, and that's the end. Well, if we deal with a 7 or 9-year-old child with intussusception, we should not just reduce the intussusception radiologically, but we are obligated to operate on the patient because the possibility of having a leading cause, more specifically a lymphoma, or a tumor is there. So it's a big difference between operating a 6-month-old baby with intussusception, reduce it radiologically and send it home, whereas in a child that's 7 or 9 years old, the patient must be operated in spite of, even if you already reduced intussusception, the patient should not go home. I remember one specific patient that the 9-year-old child with an intussusception, and we reduced intussusception and we offered the family an operation. The family refused, and a few months later, I learned that the patient died from a lymphoma. So that's a big difference, unrelated to your case, but it's important to mention.
Yeah.
Perfect. Thank you so much, Dr. Alogali. We're now going to move on to the next case. So I would ask you to mute your microphone, please. That will be presented by Dr. Carolina Giraldo from Mexico. Welcome, Dr. Giraldo.
Thank you. Good morning. My name is Carolina Giraldo. I am Pediatric Colorectal Fellow in National Institute of Pediatrics here in Mexico. This case is about a 6-year-old male patient with a history of constipation since birth. His first stool was 48 hours after birth, and then bilious vomiting present. Laparotomy due to bowel obstruction was done with LAT procedure for intestinal malrotation at the age of 11 days. At 5 years old, he presented 1 week without fecal evacuation with retention of contrast medium, laparotomy and ileostomy, plus rectal biopsy was done, and they observed a transition zone at 12 centimeters above the anus. Rectal biopsy reported no ganglion cells. This patient was referred to us for bowel obstruction, even though he's got an ileostomy. We found a patient with severe malnourishment, abdominal pain, and distension. The output from the proximal stoma was liquid and fetid. Abdominal X-ray showed dilated loops of a small bowel. Proximal stoma was stenotic. With this medical history and X-ray, what will you do? A, take the patient immediately to the OR for a laparotomy procedure. B, start IV antibiotic management plus irrigation through ileostomy and rectum. C, rectal biopsy. D, I don't know. The majority respond start IV antibiotic management plus irrigation through stomach. So we initiated IV antibiotics and irrigation through ileostomy and rectum, but this is the image after irrigation that were not effective. We observed a bowel obstruction. We realized a contrast enema, and the pathology service reviewed a confirmed rectal biopsy with no ganglion cells. Here is the contrast enema, show the transition zone at the rectosigmoid level. So we would have liked to do an ileostomy and remodeling only, but the patient lives 70 hours away from our hospital, and his socioeconomic status was extreme poverty. So we decided to perform the definitive correction at once. First, we do a central line insertion, prostatectomy, partial colectomy, pull through of the left colon with colorectal anastomosis and closure of ileostomy. This is the image of the surgery. We started the operation with central line insertion, and then we perform a full thickness prostatectomy with Swenson technique. Then we perform a laparotomy with extensive lysis of adhesions. We mobilize the left colon, dividing the left gutter and colosplenic ligament to gain length for the pull-through. A colonic biopsy was obtained 5 centimeters proximal to the transition zone in the left colon. The pathologist reported presence of ganglion cells. The cecum was not in the right lower fossa. We restored the gastrointestinal continuity with a ileocolostomy. We pulled through the normoganglionic left colon. The colon was positioned in the left side of the abdomen and the proximal bowel in the right side. Remember, he had a previous LAT procedure. Then we descended the left colon and completed the colorectal anastomosis. To do this part, we lifted the lower limbs in a lithotomy position, so rotation to the prone position was not necessary. Parental nutrition improved the general conditions of the child. This patient presented superficial wound infection. Otherwise, he had a satisfactory postoperative course. Rectal dilations were initiated and the parents were trained on how to do it. 2 months later, this patient came to our post-op visit and we found a patient with weight gain of 2 kilograms, evacuations every day, no abdominal distension, as you can see in the pictures, and he refers no pain. This image on the left was his X-ray, so he was started on Senna treatment. Discussion. Ileostomy is a fair temporary treatment in patients with chronic colonic obstruction, but the stenosis of the stomach can complicate the course of this patient. We must always keep in mind the possibility of such an event and be very thorough with the details when constructed an ileostomy. Thank you so much for your attention.
Thank you very much, Dr. Giraldo, for this excellent case. I think it brings several points. Number one, I have personally never seen malrotation in Hirschsprung. I think it can certainly happen, but I have never seen. But I just want to take this opportunity to remember everyone that is watching, if you have a patient with anorectal malformation, a patient with Hirschsprung, a patient with myelomeningocele that have malrotation and you are doing a LADS procedures, those are good cases not to do an appendectomy as part of your LADS procedure, because in some patients, the appendix will be very useful for a future Malone and Mitrofanov. So I would say if we know ahead of time that there is a colorectal condition, try to preserve the appendix when you do a LADS procedure. And I also like the fact that in this patient, the big problem was not the Hirschsprung operation itself. It was just the construction of the stoma. Stoma is a very common procedure in pediatric surgery that unfortunately has large numbers of morbidity and mortality that we pediatric surgeons usually don't talk about, we don't publish, but we also know it happens every day in our hospitals. So whenever we do a stoma, we truly have to do it meticulously and we have to check the patient post-operatively. So a patient with a stoma in an abdominal x-ray, you will see that the bowel proximal to the stoma is dilated. Most likely this patient has a stricture. So another common problem in ileostomies is prolapse. So whenever we are creating an ileostomy, because the ileostomy is the ileum is completely free in the abdomen, what we have learned is the way to prevent prolapse is creating the stoma close next to a fixed portion of the bowel, but the ileum is completely mobile. So what we do is we suture the proximal bowel next to the stoma to the abdominal wall in an attempt to avoid prolapse. In this case, the problem was stricture. And the way we prevent this, when we create a stoma, we cut circular the skin, we cut circular the subcutaneous tissue, the muscular, the aponeurosis, and we make sure we can insert a finger on this hole. Some people just do a puncture opening, and that's when we usually see strictures. So congratulations on this case. I'm glad he finally reached your service and is doing well. Have comments? Any questions or concerns from the audience? Let me see if there is anything in the chat. And I don't see anything. So we're gonna move on to the next case that I understand is gonna be presented by Dr. Ugarte, also in Mexico from the Instituto Nacional de Pediatría. Welcome.
Sorry, thank you for your presentation. Good morning, I'm Chanel Ugarte. I'm a pediatric surgery resident from Hospital de Niños, Dr. Mario Ortiz Suarez, Santa Cruz, Bolivia. I'm to observer in colorectal clinic of National Institute of Pediatrics in Mexico. This case is about a small patient of 10 months old with past medical history is diagnosis of anorrectal malformation without fistula at the birth. Then in other hospital was made a colostomy at 2 days after birth. The approach of this patient showed a sacral index 0.54, dorsal hemivertebra, bilateral club foot, punctured kidney, MRE pending to rule out probable lumbosacral dysgraphies. In this distal colostogram, we can see the rectum bladder fistula, which is above the sacrum bone. And finally, in MASH, you can see leak of contrast medium. The radiology followed us. We perform a laparotomy after hour of colostogram because the patient has persistent metabolic acidosis and acute abdomen and mixed shock. In the peritoneal lavage, we don't see the site of perforation, but after peritoneal lavage, the patient showed clinical improvement. What is your proposal for treatment in this patient? A, PSAR, B, laparoscopy and PSAR, C, laparotomy and PSAR, D, only laparoscopy and enoplasty. The B and C is the majority, laparoscopy and PSAR, and laparotomy and PSAR. We decide on a mixed approach. The electrostimulation showed the location of the muscular complex just began the scrotum. After sagittal approach, we perform a laparotomy. We found adhesion in the pelvis. We ligate the fistula at the entrance to the bladder with absorbable suture. In this video, you can see the pelvic horseshoe or fused kidney. Then the blood vessel, we had to ligate to get enough distal length of the rectum to allow it to descend through the pelvis without tension. And finally, at the bottom of the pelvis, you can see a forcer to pull the rectum to perform the anoplasty. To perform the anoplasty, we lifted the baby's feet and raised the pelvis. We close the posterior sagittal incision and construct the anoplasty on this position. And to the right, you can appreciate the final appearance of the anoplasty and wood closure. That's all. Thank you for your attention.
Thank you very much. Can you go back in the slides to the image of the high pressure distal colostogram? I just want to emphasize it's a beautiful colostogram. Perfect. So it's just when there was a question about how to approach this patient, somebody mentioned PSARP only. And I just want to emphasize that this is a very high rectum. And when we enter posterior sagittally, here we are seeing the last bone of the sacrum. So it's going to be, and this is not a perfect lateral position, but it's very dangerous to look for the rectum in cases of rectal bladder neck fistula posterior sagittally. It is very high. So for those cases, we recommend the separation or the finding of the rectum through the abdomen, because that's a safe way and because the rectum is very high. When entering posterior sagittally, what happens is that sometimes surgeons may injure the urethra and other structures, bladder, while looking for the rectum. So for those cases, you should look for the rectum through the abdomen, either with laparoscopy or laparotomy. I know Dr. Peña wants to comment too.
Yes, can we go back in the slides to see the beginning of the presentation? Because it was not clear to me at what point the patient had metabolic acidosis and shock. That was not clear. Can you start again from the beginning? Show the slides. First slide. Can you hear me? And freeze. Can you hear me?
Yeah, they can.
Yes, Dr. Peña. The patient has a contrast enema in abdomen. We don't, because the slide not present this image, but the patient has a metabolic shock. We perform only lavage of peritoneum.
No, it's not clear in the presentation from the beginning what happened. The baby was born and had a colostomy, right? The baby was born in another institution and had a colostomy.
Yes, the patient has a colostomy, and then the radiology performed the distal colostogram. In this distal colostogram, the patient has a liquid at the contrast medium at the abdomen.
Oh, that was not clear in the presentation. So now let me tell you, we call the colostogram, we specifically say high pressure distal colostogram. And over the last 40 years, we had 2 events of perforation during the distal colostogram. Those perforations occur in patients that had a rectal bladder neck fistula. In other words, if the patient has a If the patient has a, and also in patients that had a transverse colostomy, if the patient has a descending colostomy, we have never seen that perforation. What happens when you open a transverse colostomy and then you inject contrast material, you need a lot of pressure in order to make the contrast reach the lowest part. And you need a lot of pressure to make that contrast go into the bladder. And as the radiologists keep putting pressure and eventually may perforate. When the perforates is a very, very serious complication because the contrast material, at least the water-soluble contrast material that is used here, is a hyperosmotic. So immediately sequestrates an enormous amount of fluid in the peritoneal cavity, and that produces shock, of course, acidosis and so forth. So the main message of this case is when you do, first of all, we don't do transverse colostomies. We do not do transverse colostomies. One of the inconveniences is exactly what you are seeing. It's very difficult from a transverse colostomy to reach with enough hydrostatic pressure the lowest part of the bowel. In addition, the transverse colostomy, the problem is that you cannot clean the distal bowel. You cannot, when we open a colostomy in a newborn, we always irrigate the distal bowel to leave it completely free of meconium, completely collapsed. In that way, the patient will not have a megarectum at the time of the pull-through. We'll have a completely collapsed rectum, which will facilitate the pull-through. In addition, in bladder neck fistulas, the meconium goes into the bladder, but also the urine goes into the colon. And it's absorbing the colon and contributes to the hyperchloremic acidosis. So we do not do transverse colostomies for those reasons. So now I understand the patient had a perforation during the, and then did you do the pull through at the same time of the laparotomy for the perforation? That was not clear to me I didn't understand. You saw the patient with acidosis and shock because of the perforation of the colon. You operated on the patient. Did you do the pull through at the same time?
They did not. They just washed the peritoneum and they did not find perforation.
You did not find perforation. Do you have an X-ray showing the contrast material in the peritoneal cavity?
I think they're having problems with connection.
I think we have technical problems.
Okay, I think we're having trouble with the connection. So I'm just gonna speak generally. If there is a case of a perforation, yes, unfortunately, the perforation is not just one little hole, it's usually an explosion. It's extremely unusual, but patients get very sick when that happens. So we do recommend operation, suturing, cleaning of the abdomen, and those patients usually go to the intensive care unit due to fluid shift. And we would not recommend the pull-through at the same operation because, again, the patient is sick at this moment. Anything else? Okay, so we'll have to move on to the next case that is going to be presented by Dr. Itzel Lizarraga. She is visiting us here in Colorado, but she's originally from Mexico. Welcome.
Thank you. Good morning to everyone. So this is a case in an 18-year-old boy with CHARGE syndrome, neuromuscular disorder, and congenital anomalies with chronic constipation. At the age of 1 month, a G-tube and aneurysm fundoplication was performed due to a gastroesophageal reflux and poor feeding. At the age of 8 years, the patient presented constipation and gastroenterology started on him Senna and Miralax. 1 year later, he was constantly having involuntary bowel movements every day and significant abdominal distension. At 13 to 14 years of age, the patient continued with abdominal distension and severe bloating after feeds, with painful abdominal discomfort. When he was 15-year-old, present acute respiratory distress, abdominal pain due to a gigantic abdominal distension. In the emergency department, a volvulus was confirmed and a colonoscopy reduced the sigmoid volvulus. This was the X-ray taken in the emergency department. We can see all the colon dilated, air filled, and we can't see the diaphragm. The CT scan showed the entire colon with a massive dilation, causing restricted thorax in the patient. What would you do next? 1, bowel management with Senna, rectal enemas, or sigmoidectomy. So the majority responds rectal enemas, and in second place, sigmoidectomy. In this case, because the sigmoid was enormous with a high risk of recurrence of another volvulus, the surgeon decided to perform a sigmoidectomy and injection of Botox in the anal sphincters. After the sigmoidectomy, the patient was stable with no abdominal distension, stooling every day with Miralax and fiber. 1 year later, he develops progressively a worse abdominal distension and abdominal pain, and gastroenterology requests a contrast enema. This is the contrast enema of the patient. We can see the entire colon with severe dilatation, and radiology and gastroenterology suspected a Hirschsprung disease due to the rectal sigmoid radio. With this contrast enema, what your approach would be? Continue with Miralax and Senna, rectal enemas, or examine under anesthesia and rectal biopsy. The majority answer exam under anesthesia and rectal biopsy. That's that we perform to exclude Hirschsprung disease. The rectal biopsy showed ganglion cells in the submucosal and mesenteric plexus. Calretinine was positive in the lamina propria. Then we performed a laparotomy and found a massive dilation of the colon. In consequence, we did a near total colectomy, leaving only the ascending colon. In this picture, we can see the entire colon is dilated and the ileum looks good. What would you do if the right colon does not reach enough for the colorectal anastomosis? Ileostomy, ileoanal pull-through, the lawyer's procedure, Turnbull procedure. Okay, the majority answers ileoanal pull-through, and in second place was the lawyer procedure. We did an exploratory laparotomy, near total colectomy, colorectal anastomosis without the lawyer's procedure, and creation of a continent enterostomy. The lawyer's procedures involves full immobilization of the cecum and the right colon with a craniocaudal anticlockwise rotation of the cecum. In such way, the anterior surface is against the retroperitoneum and preserving the ileocolic junction. We did not perform an appendectomy because we use the appendix for a Malone procedure, and we did not do a clockwise rotation because the mesentery of the ascending colon would obstruct the ileum. We can see in the first image the right colon flexure and the cecum down. Then we do the anti-clockwise rotation. And in the last image, we can see the cecum is up and the colorectal anastomosis is near to the pelvis. Another option is the turnbull procedure. This procedure entails total mobilization of the transverse or right colon and then create a window in the mesentery, performing a transmesenteric mobilization. And this procedure allows a safe and tension-free anastomosis and prevents an ileal obstruction. This is the pathologic specimen. It was informed as markedly dilated colon with no significant histopathology, and ganglion cells were present. Currently, our patient is tolerating oral and G-tube feeds, stooling every day with antegrade enemas and no abdominal discomfort or distension. Thank you.
Thank you very much for this very interesting case and for teaching us some surgical procedures. I have never done a turnbull and I would be concerned. In the drawing looks fantastic, but I think I would be extremely concerned to do it in real life. And I just want to comment that the intraoperative picture is impressive for the massive dilation of the colon. And it's almost unbelievable that pathology reports normal. And what I think is that over the next years, we're gonna learn more about pathological abnormalities in those colons that we currently don't see because we don't know in terms of histopathology, but I'm sure there gotta be abnormalities that we are just not familiar with. So if there are questions, please type in the chat and I'll let Dr. De La Torre comment on this case.
Thank you, Andrea. So this patient was very challenging, but we need to learn many things about this case. The first is if the patient has already long-standing constipation with motility issues, we do not recommend the use of polyethylene glycol. Here in the United States, it's Miralax. So this patient was on this medication for probably 8 or 10 years, trying to move this unuseful, very dilated colon. So the patient was having a lot of involuntary bowel movement. This patient lives with his 2 grandmothers. The parents abandoned him, and now he lives for the last 10 years with the 2 grandmothers. So this patient also has a social problem. But anyway, we need to be very careful. We need to pay attention on this patient because already know that Carla published a couple of years that polyethylene glycol is not effective or is less effective than Senna or Senosides in these patients with constipation. So this is the first lesson that I want to address in this case. The second one is if we have to do really a rectal biopsy in a patient that was having normal bowel movement for 8 years, and then suddenly a contrast enema shows history, even without history of colitis or obstruction. In my mind, I recommend not to do a rectal biopsy. Usually, if the patient has 8 years having daily bowel movement, and then suddenly he starts constipation 8 years of life, that's not a typical picture of a patient with history. But in this case, it was a lot of pressure from radiology and the gastroenterologists, the GI group, that they don't know what to do with this case. And then when the contrast enema shows like a rectal sigmoid ratio suggestive of Hirschsprung, we have to do it. It's not our common practice, but we have to do it because it was a lot of pressure from the grandma and the GI. And okay, we said, okay, let's do the rectal biopsy. And that was very helpful because we have to do the good clean out in the OR, the patient improved, and we showed the demonstration that the patient was not a Hirschsprung patient. In the questions, there was also if we have to do a ilio rectal pull through, like a total colectomy and then a pull through of the ileum. We do not recommend to do this in this type of patient because this patient has neurological issues, like Itzel already explained. He was always on diapers at home, mostly from involuntary bowel movement. So that's why we decide to preserve the rectum and some of the right colon. And the right colon it didn't reach I won't say the peritoneal reflection, unless we have to do these maneuvers. You can do the Turnbull that it's explained very well, and the lawyers. So we decide for the lawyers because the anatomy in these patients allows to do this maneuver. We create a malone because the patient most probably is not going to have fecal control because his neurological issues. So at the end, the patient went home very well. The flushes using the malone is working very well, and we're very happy with this case. So we learned a lot with this patient. I don't know if somebody have any question about the patient or the case.
There are many questions in the chat. While you start looking at the questions, Luis, I'm just gonna comment on the previous case, the case with rectal bladder neck fistula. There was a mention of metabolic acidosis, and I just wanna remember everyone that in those cases, usually the acidosis happens because of absorption of urine in the colon. So that's usually the cause for the acidosis that we see. So Luis, if you want to answer the questions, there are many questions in the chat.
Yeah. So Dr. Farid is asking the histopathology of the resected bowel after sigmoidectomy. This sigmoidectomy was performed years before by another colleague in the hospital, and it was reported like just ganglion cells. They don't do anything else in this specimen. The procedure, I'd like it a lot. The lawyers and Turnbull, I never hear about it. Yeah, these are not new procedures. This was described in patients with colorectal cancer in adults. I have used this in patients with Hirschsprung I don't want to say many cases, but we have a good number of cases doing this when we have to mobilize the right colon to avoid obstruction of the distal ileum. We can do the lawyers or Turnbull in total pouch colon. I don't know. I don't have experience doing this in pouch colon, so I don't want to say yes or no. In the lawyer's procedures, if the right colon is so small that lies in the pelvis and the appendix cannot reach the umbilicus to perform a malone, will you do an appendectomy? No, the advantage of to turn the splenic flexure, the hepatic flexure in the pelvis is the advantage of the lawyer. So you can do that. If you are thinking that the patient is going to need antegrade enemas, yes, you need to avoid the appendectomy. Already Andrea explained in what cases we do not perform appendectomy. Have you experienced problems with the colon compressing the DJ or proximal jejunum in the splenic flexure pull through. Okay, when you need to do a pull through and you want to mobilize the splenic flexure or the mid colon, mid transverse colon into the pelvis in a patient with Hirschsprung, yes, sometimes these compress the distal ilium. That's why we use the transmesenteric pull through, transmesenteric maneuver, whatever it is, described by Turnbull many years ago. Yeah, that's the idea. We had cases operated last week. This is for you, I think, Andrea. We had case operated last week with anorectal malformation, with septated vagina, V-coronate uterus, and total pouch colon, double appendix, and double cecum. That girl had labeled as case of persistent cloaca with pouch colostomy made in neonatal life. You want to comment? Andrea or Alberto, you
Sorry.
want to comment?
Yes.
Yeah.
I don't know where the pediatric surgeon is coming from. In India, it's extremely common to find these pouch colons, but in other parts of the world, what we see is cloacal exstrophy or covert cloacal exstrophy. Those are the cases that would be similar to the ones you are describing. What I don't understand is that you did a total colectomy and ilioanal pull-through. So those are patients without the anus. So if you just bring the ileum down, there's no way you can keep this patient clean. So I would say in a similar case, what you should do is even that abnormal colon, that pouch colon, you should bring as an end colostomy. And then do bowel management through the stomach, because the only chance of this patient to have a successful pull-through, meaning that she will be clean in the underwear with enemas, is if she has a little bit of colon. Once you remove the colon, if you just bring the ileum down in a patient without an anus, you just made a perineal ileostomy. And this patient, there's no way to keep this patient ever clean. So I suspect she will need an ileostomy in the future. I'm happy to talk more about this case, or if you want to present next month so we can all learn. But the message is you can only do an ilioanal pull-through if the patient has an anus. If it's a patient with anorectal malformation, no anus, there's no way to do an ilioanal pull-through. You're just doing a perineal ileostomy. And this patient, there's no way to keep those patients clean. I hope I made myself clear.
Yeah, this case is from Pakistan.
Okay, okay.
There is another question from Rosie Kimbert Montes. She's a colorectal surgeon now working in the group of Dr. Asuara, I think so. Hi, Rosie. She said, I have no clear the reason of my long procedure. Did you try rehabilitation? I think bowel management after the lawyer's procedure? No, Rosie, we didn't. We tried to do enemas, or we tried to do irrigation in this patient, but because his neurological issues, we don't want to present the picture of the patient, but the patient has many deformities, is very strong, and he lives just with two very old grandmas. So trying to do any rectal procedure, it is impossible. Now with the Malone, it was very easy to do the clean out of the remaining right colon and the rectum, and the patient is clean. So that's why we tried to do enemas or irrigation, but it was very difficult for the new parents for this patient. Okay.
we just want to clarify something about terminology. We don't use the term intestinal rehabilitation because we don't know what that is. When we use those terms, intestinal rehabilitation, are we talking about giving enemas? Are we talking about giving laxatives? Are we talking about biofeedback? Are we talking about what is that? So the rehabilitation terms means that there's a patient with an abnormality and we are going to make him normal, and we don't do that. We use the term bowel management, and which also is not very specific because doesn't mean much. Bowel management of the bowel, but we prefer to be specific. Are we using enemas for fecal incontinence? Are we using enemas for constipation? Are we using suppositories? Are we using all that is bowel management in one way or another. We try to avoid those terms like rehabilitation.
Alberto, I think the term is what the Spanish translation of bowel management, because how do you translate in Spanish bowel management?
I insist that bowel management is also very non-specific, and that's why we should refer to specific management. What they were doing, enemas, laxatives, be specific rather than using the term rehabilitation. Rehabilitation is as bad as bowel management, or even worse, because we don't rehabilitate these patients. We don't make them normal with those treatments. You know, with rehabilitation, you have a broken arm and then they exit until you are normal. But here we are not doing anything like that. So, and bowel management is also non-specific. We should be try to say, if you tell me I have a patient on bowel management, I don't know what you are doing. Are you doing enemas? Are you doing what? So I immediately ask, what specifically are you doing? And I think we should promote that to understand between us, colorectal pediatric surgeons.
Yeah, the question is more related to the translation of bowel management in Spanish.
There is no manejo intestinal. That's the translation will be manejo intestinal, as bad as bowel management. That's manejo intestinal. This is.
That's it.
Okay. Well, I think we're going to end today's meeting. I would like to thank all the ones who joined. We have pediatric surgeons from Libya, Pakistan, Mexico, United States, Bolivia, Dominican Republic, Yemen, Ukraine, Uganda, Armenia, Iraq, Ecuador, Morocco, Chile, and Bangladesh. So I hope I didn't miss anyone, maybe Pakistan I mentioned. So, and we look forward to see you all next month. Please send your cases and thank you for joining. Bye-bye, everyone.